Hello, everyone, and good evening. Good evening, everyone, and hello. It's a pleasure to be back here with another one of our COVIDsurg webinars. And it's me tonight, Anil Bangu. So I'm a colorectal consultant surgeon in Birmingham and one of the COVIDsurg investigators from the original batch. And it's a pleasure to introduce Dimitri. Hello, Dimitri.
Hi, yeah, my name is Dimitri. I'm a public health doctor and part of the COVIDsurg team. So thank you everyone for joining today.
I thought you were going to say you're the next UK Prime Minister.
That could be anyone.
Okay, well, let's see how you do. Look, it's a real pleasure to speak to everyone tonight, and thank you very much for joining us. We've got the first global presentation of the COVIDsurg 3 results. And I think no matter what this shows, it will affect all of our practice as these are problems I encounter every day. So what we're going to do is Dimitri's going to present the methodology and results, but we're going to try and do it in a way that we're going to have a conversation around all these things and talk about the strengths and the weaknesses. And as we go through the results, we're going to talk about what they mean, because we no longer deal with one group of patients. We all deal with elective patients, emergency patients. So we'll try and break it all up. As we go, please do fire through any questions you have, and I'm going to keep an eye on them. I might not be able to answer them all, but we'll pick them out and we will get to them. So, it's been quite the journey for us, Dimitri. It's been the journey for everyone, I think. COVIDsurg launched pretty quickly in March 2020. And this is the third rung of studies, and it's great to get it out. Do you think this data is timely?
Yeah, I think so. At least one thing is that when we started COVIDsurg 1 in March 2020, I think many people thought that COVID would be a really difficult time, but it would be a relatively short pandemic, that we would have, maybe large numbers of patients being unwell over a period of 8 weeks, 12 weeks, and that then things would go back to normal after that. But unfortunately, as we've all discovered, this pandemic continues to have a huge impact on most, essentially every aspect of our lives, even now. And that includes the surgical care we provide for our patients. So as we in the Northern Hemisphere now go into winter again, sort of through autumn into winter, I think the expectation is that there will again be large numbers of patients developing symptoms and testing positive for COVID, certainly in the UK, and I think around the world. So I think this data will be really important because this isn't a problem that's gone away. This is very much a live issue.
Well, I'm certainly preparing for winter. And thinking about what I'm doing with these patients. So just before we start, could you launch the first poll, please? So, and that's asking sort of what you're doing with a patient who has, so the first question is about your elective activity, since we're talking about winter. And we'll have one of them back up. Okay, so I will revert. So the first question is going to be around delaying elective surgery. So before we start, before you see the new data, it'd just be really interesting to know what people are doing. So which patients who test positive in the elective setting are you currently delaying, if you're delaying them at all? Yes, Dimitri.
Yeah, so Neil, I just while waiting for everyone to vote, I just thought perhaps we could open with a bit of a summary of our earlier studies, just for context, how we've got here. So if it's okay, maybe I'll start sharing the screen whilst people are voting.
Definitely, yes, please.
So
you keep going. I'm gonna cut in and interrupt, but please feel free also, Dimitri, to ask me any questions.
Okay, so I just thought first to just mention the first study we did, COVIDsurg 1. This study just captured data from patients who had perioperative SARS-CoV-2. So that means they had either had a positive test or a clinical diagnosis of SARS-CoV-2 infection in the 7 days before or the 30 days after surgery. And it was a massive team effort, but we worked really quickly so that we had data for 1,000 patients that we submitted to the Lancet, and that was published at the end of May 2020. And that study found that the mortality rate overall across all patients was 24%. And that was obviously quite concerning because that is much higher than anything you would expect, even in a relatively high-risk group of patients, let alone a group that included many patients with elective and minor surgery. And in addition, consistent with the literature from medical patients with COVID, we found there was a very high rate of postoperative pulmonary complications. So just about half the patients were having pulmonary complications. And those were the patients who then had particularly poor prognosis. 40% of those patients were dying. So that was really quite concerning. So I just thought after that, we did a number of other analyses and studies. And maybe, Anil, you'd like to summarize from this diagram the totality of the COVIDsurg evidence.
Yeah, well, I mean, it was a sad time. So, you know, our publications are definitely muted in celebration, and there's no real celebration. We tried to get the data out as quickly as possible. I think when I look back, the things that made a big difference with the timing of surgery issue, I still use that data today when I see patients who need elective surgery. I think if I think back to that first year, all the sort of the chaos and uncertainty around testing, I think the testing data helped. We published in the Lancet Oncology on COVID-3 pathways. And I think that all helped us, helped us set up the safest systems we could around the time. I know a lot of surgery didn't get done, but our modeling has demonstrated that we probably saved thousands of lives during the pandemic through those measures alone. And, you know, we had 24,000 downloads of our patient information in that first year as well. So, I mean, it's a humbling honor to have been part of that. But, you know, everyone's trying to reopen elective surgery again. There's staffing troubles around the world. I read an article recently that most health systems around the world have moved into what's called firefighting mode. So everyone's trying to deal with the emergencies. And, you know, here we are trying to restart safe surgery. So, yeah, you know, this feels like I don't know if it's the final piece in the puzzle. I sort of hope it is, but it's definitely the next piece in the puzzle.
Yeah, and just to reiterate, I think the timing of surgery, because we'll be coming back to that topic. Our first study had only included patients who tested positive, and so we only had those perioperative SARS-CoV-2 patients. So that's why we did the second study, the COVIDsurg week study in October 2020, to look at what the best timing of surgery after a positive test was. And in that study, we captured both patients with current, previous, and no SARS-CoV-2. And there we showed that we should wait at least, there's a typo on the slide, it should be 7 weeks, not 7 days, after a positive test before we operate on patients to minimize their risk. But that data was from October 2020, which was, that was before we had any of the variants. So that was the original virus. And it was obviously before the vaccinations had been rolled out. So
on that point, Michi, let's get the result of the poll in just while you've mentioned it. So the current recommendations are 7 weeks. So could we just have the results of that poll up, please? And we'll just see where people are around the world and what people are doing. Yeah, so while we're waiting for that, there we go. So which patients, when they test positively for SARS, are you delaying? So most people, 61%, it's all SARS positive patients. But then we're beginning to see some stratification. So 18% symptomatic patients only, 17% high-risk patients only, and 4% aren't delaying. And Dimitri, as we go into this and as we talk about the results, we know we've had feedback that people want to open up everything, but just to manage expectations, I was thinking this morning, in 2019, if I'd had an elective patient who I saw in clinic who had an active pneumonia, let's say that was just a viral pneumonia, I mean, I wouldn't have operated on them anyway. I would have delayed it there. So this concept of symptoms, I think is quite important to me, and I think so and I know you're going to get into it, but my question is, will you be differentiating between symptomatic and non-symptomatic disease?
Yeah, that's one of the sort of factors we've looked at. So definitely look forward to kind of sharing that data with you.
Okay.
Maybe we can move on to just wrap up what the aim of the study was. So as I mentioned, our previous data was all collected during the first COVID wave, when we had some people call it the wild type, the original virus. And we know that the Alpha, the Delta, the Omicron variants were all quite different to the original virus in various ways. So how good is our evidence from the first wave to what's going on now? We didn't know. And it was also before the rollout of the SARS-CoV-2 vaccine. And we know that has obviously had a massive impact on the risk of complications should you get infected with SARS-CoV-2. So really, we wanted to collect data that would be a bit more up-to-date and generalizable for this, what is so far the Omicron era. So that was what we were aiming to do.
And then correct me if you think I'm wrong, but and we're not virologists, but I was reading the other day that winter might be dominated by Omicron variants. So this data on Omicron, I think, will impact directly on what we do over winter and maybe even into next year. I guess we don't know when the next variant's going to come, but at the moment, we're still looking at Omicron, I believe.
Yeah, so I think there's now quite a number of subvariants of Omicron. So at one point, BA.5 and BA.6 were the predominant variants. But I think everything we know about them, they behave in a quite similar way to the original Omicron variant that was around when we collected this data, except that they're more transmissible. So you're more likely to pass it on to someone else and infect someone else. But in terms of the severity and the kind of impact on patient outcomes, they seem to be behaving in the same way. And although they're more transmissible, that's less relevant for what we're looking at in this context.
Okay, brilliant. Please do keep going.
Yeah, so just to summarize the methods, many of you will be familiar with this. This was an international multi-center cohort study, so it's observational data. We haven't intervened in any way. We've just captured the outcomes of the patients that were having surgery. And that was between the patients who were operated between December and February this year. And then we followed those patients up for 30 days. And then we've gone through a process of chasing up missing data, cleaning data, analyzing data. So that's why we're presenting this webinar to you now. But the patient data was captured between December 2021 and February. And the methodology was very similar to the original COVIDsurg 1 study. We've done that deliberately to make it easier to compare outcomes of patients now versus the first wave. So we've deliberately tried to keep it as consistent as possible. And in a nutshell, what we've done is we've collected data on patients undergoing any type of surgery with perioperative SARS-CoV-2 infection, meaning that they had a positive PCR test or rapid antigen test in the 7 days before or the 30 days after their operation. So we've captured all these patients, any type of surgery, any type of patient, any age, and we've then looked at the outcome being 30-day mortality. I think if I put this data in context, we are seeing more papers coming through. I mean, we've seen a lot of papers during COVID, haven't we? And we've seen the journal impact factors reflecting that. I still think this is unique data. And I don't mean that to show off. What I mean is that the communities come together and we're probably going to see data that is going to be multi-country and that no one else can really capture. And I do that just to frame what the results are going to be. But I think it's important we do understand the methodology behind this. I think this is as well controlled
a study as can be delivered on this topic. Of course, it has limitations like all observational cohort studies. But I think, Dimitri, my analysis of what you've done is that you've minimized the risks of bias. So well done on delivering this study, and I think we're excited to see the results.
Yeah, I mean, just to throw a caveat in, obviously, as everyone who's taken part knows, the way we've collected this data is we've asked frontline surgical teams to collect data in their hospital on patients who tested positive. Now, that has a big advantage, which is that it means that we can collect data that wouldn't be routinely available in many of the routine data sets that might be used. So in England, we have the hospital episode statistics, and in other countries, they have other databases like NSKIP. So we're able to capture some of the detail that isn't available in those data sets because they weren't designed to look at COVID-19 specifically. And that does mean that we potentially have a granularity that is available in very few other large data sets. On the other hand, there is obviously some uncertainty. Have we captured all patients undergoing surgery who tested positive? And there are limitations around that. However, we've worked really hard with our national leads who did a fantastic job of trying to spread some training materials to get people up to speed with what we were doing, how to find patients, make sure we weren't missing any. So we've done everything, I think, that is feasible. There are always going to be some limitations, as you mentioned. But I do think this is probably the only large-scale international real-world data that's available. So let's not keep people waiting too much longer for the key results and how we're going to discuss them. What I would say that there'll be a recording of this on YouTube, and we will disseminate these results quite widely. So if anyone is keen for us to present, it'll be on Zoom to your hospitals or to your national associations. We are delighted. The COVIDsurg team is delighted to do so. So Dimitri, over to you. Okay, so the results. So we've just got the highlights here, really. But thanks to everyone's hard work, we had over 940 hospitals taking part around the world in 89 countries, which is a fantastic effort. So thank you everyone who took part. And thanks to that hard work, we've collected data on very close to 20,000 patients with perioperative SARS-CoV-2. So that's an amazing achievement. And that means we have sufficient numbers of patients to really start to drill down to understand some of the subgroups and to really understand what's going on. So that's a really great effort. So just to kind of characterize the patients, about 3/4 of the patients were aged under 70. Almost 2/3 were ASA grades 1 to 2. So probably the majority of patients are quite young and don't have significant comorbidities. 40% were having elective surgery, so about 60% were having emergency surgery. And this is the really key result. 63% were vaccinated. Now, just to explain what we mean by vaccinated, we have defined that for the purpose of our analysis as having had at least one dose of any of the sort of approved SARS-CoV-2 vaccines at least 2 weeks before the date of surgery. And that's because we've got really good evidence, I think, from across the board that the vaccination doesn't really kick into effect for 2 weeks. So you need to have been vaccinated 2 weeks earlier for it to have a really good effect. And we've even included people who've just had one dose, just partially vaccinated, in our main analysis. So that's just explain that. So after all of that, the overall mortality in these almost 20,000 patients was 5.8%. So that's a really interesting result because, as you remember, the overall mortality in the original study was 23.8%. So that's a massive reduction. I mean, do you think this sort of mirrors your experience, Neil, in the real world?
Look, that's a really good question, and if I react as someone who hasn't seen this, my first thoughts are: is that a reflection of the disease, as in Omicron's less severe, or is it a reflection of selection of patients? And my feeling is it might. I'll let you get into the data. It might be both, but for me, the key figures are actually the inverse of this, because this includes 60% of people who had emergency surgery. And it thus includes about 40% of people who are ASA 3 to 5. So it's not just, these are not just elective patients undergoing minor operations, but by the very definition of the data, this is still major surgery. So that. What I take from this slide is, firstly, major reduction in mortality. And secondly, that's probably across the board. And that interesting that 2/3 of people are vaccinated. I mean, most of the people I end up operating on these days are vaccinated, but across the world that clearly isn't the case. But so yeah, that's my first reaction. But let's put it in context. Keep going.
Okay, so this slide is a little bit complicated, but what this shows is how the mortality rates, 30-day post-operative mortality, breaks down by whether you had elective or emergency surgery, whether you're under or over 70 years old, and whether you're ASA 1 to 2 or ASA 3 to 5. So we're starting to understand a little bit about the different groups of patients who might be lower or higher risk. And then going across the screen, what you can see in the 3 columns, if you like, in the brown is the 30-day mortality that we captured in the COVIDsurg 1 study. So this is the mortality rate from the first wave. The middle column is the COVIDsurg 3 mortality in unvaccinated patients. So these patients have had no vaccination. And in the last column, it's from COVIDsurg 3 in the patients who have had at least 1 vaccine dose at least 2 weeks before surgery. So I think what's quite clear is that even the unvaccinated patients, you can see that their mortality rates have dropped considerably compared to the first wave, when obviously there were nobody was vaccinated in the first wave. However, the vaccinated patients are the ones who have the best outcomes. They have even lower mortalities than the unvaccinated patients in the Omicron wave. So reduction in mortality from the first wave in COVIDsurg 3 in the unvaccinated, and the vaccinated even lower than the unvaccinated. So is there anything there, any groups there that really jump out for you, Neil, do you think?
Well, the one thing I disagree with you on is that it's a little bit complicated, a slide. I don't think it is. I think this is exactly the slide that needs to be shown. I think this breaks down the key groups, which are the electives and the emergencies, the ages, and the ASA grade really represents their risk. And just to summarize, the first set of columns was essentially COVIDsurg 1. The middle set of columns is unvaccinated COVIDsurg 3, and the third set is vaccinated COVIDsurg 3. That's correct, isn't it?
That's right, yeah. So I think essentially we can see that there's Omicron is probably less severe than the first wave.
I think so. What I'm taking from this is, definitely try and vaccinate everyone before surgery. I think overall I'm taking that it looks less severe overall, which is good. I'm beginning to look at this and saying, can I ease restrictions on my patients? Can I open up? Can I reduce some of the testing? And those are the feelings going through my mind. But Dimitri, I look at some of those figures, and I think that some of the mortality is still quite high. If I look at the final column, which are the vaccinated patients in COVIDsurg 3, if I look at some of the the elective age 70 and above, ASA 3 to 5, 7.2%. I accept that ASA 3 and 4 predominantly, but still 7.2% is quite high. If I look at the electives under 70, ASA 3 to 5, 4%. So again, we'll get there. Overall, I take it's a significant improvement, and I want to open things up. But my gut feeling is still to have some caution here.
Yeah, I think that's very sensible. Obviously, we can't make an exact comparison to patients who don't have COVID, because in this study, we didn't collect data for patients without SARS-CoV-2 infection. However, I think you're right that when we look at some of those mortality rates, that they are probably a little bit higher than what we would expect typically. So I can see that Rebecca's written a question: what do we expect mortality to be in patients for each category prior to COVID? That's quite a tricky question, but I think overall, all patients having surgery before COVID, certainly in the UK, we would probably be expecting overall mortality to be 0.8% roughly overall. Now, bearing in mind, obviously, a large number of patients are younger patients having day case surgery, but it kind of gives you a feeling that, as Anil said, some of those elective patients who are older are possibly having, they still have an increased risk, albeit much less so than they did in the first wave.
So, Dimitri, I know, so look, we've got a priority that we want to get this published, but what I'm just taking from that question and what you just said, maybe part of the COVIDsurg 3 collaborative team could look at some accurate, I want to call it historic data, but you could look at the HES data that was published with the mortality rates and look at the English data from within COVIDsurg 3 and just see if there was a difference in mortality, maybe, to answer that. I'm not saying that should slow down dissemination of this information, but it's an interesting question.
Okay, so I think the next slide, it was to really drill down into what we discussed earlier about what's the difference between having symptoms and not having symptoms. So here we're just looking at patients from COVIDsurg 3, and we're only looking at the patients who tested positive pre-operatively, because it's quite difficult to look at symptoms in post-operative patients, because obviously it's difficult to know whether they're COVID symptoms or related to their surgery. So we're looking at patients with pre-operative SARS-CoV-2, and we split them into 4 groups according to whether they were vaccinated and whether they had symptoms of SARS-CoV-2 infection. So, and again, we've presented that by age group and by ASA grade. So here you can see that the patients who are unvaccinated and symptomatic, so they have symptoms of SARS-CoV-2 before they were operated, these patients have got really quite high mortality rates. Even in the young, low ASA patients, their mortality is 5%. And, in the older comorbid patients, it's as high as 37%. So that's really quite concerning, I think. I would think very carefully, I think, about how we manage that group. The second column along, we can see these are the unvaccinated patients who were asymptomatic at the time of their SARS-CoV-2 diagnosis. And you can see that their mortality rates are considerably lower than in the patients who are symptomatic. In the third column, you can see the patients who were vaccinated but had symptoms of SARS-CoV-2 infection. And again, these patients, despite vaccination, have considerable mortality rates, up to 26% in the older comorbid patients. And the final column, this just shows the patients who were vaccinated and asymptomatic, no symptoms of SARS-CoV-2. So these patients are having the lowest mortality rates at 30 days. So, Anil, what would be your sort of key take-home message from this, do you think?
Well, I think myself that I don't want to delay some of these patients. And I get questions from colleagues saying, look, we just need to get on. But this actually reinforces some of my thoughts that if you have a symptomatic patient, that they are going to still require some form of delay. I think that's probably true. I wouldn't want to operate on someone if they had a non-COVID viral pneumonia. If I could avoid it, I would be looking to delay them. I'm also thinking that as we talk about relaxing things, I'd probably delay them for a reasonable amount of time, and that 7 weeks will probably, in my mind, stick. That's probably an evidence-based recommendation, even if they're vaccinated. The asymptomatics are really interesting, and this is the group where I would be looking to definitely unlock things. And I I still think some of those mortality rates are quite high. So I would still be very cautious. But there's some groups here that the younger patients, the lower risk, where, I might choose to give them a very short delay. I might not operate on them if they keep testing positive, for example. But the concept of pushing them out for weeks and weeks and months, I probably, and I've had patients like this myself where they've had what I consider to be relatively aggressive cancers. They're young, they want to get on with it. We've got the operating space. And so I probably would accelerate some of these people. So that's my thought. So I don't think, Dimitri, I put it to you, we can't, based on this slide alone, and just to confirm to everyone, this is Omicron only, we can't just say operate on everyone and lift all restrictions on delays and things like that. I think some of those mortality rates are too high. What do you think, Dimitri?
So I think, as you say, we need a bit of nuance. So, for example, I think the patients under the age of 70, ASA 1 to 2, so young, fit patients who are vaccinated and asymptomatic, their mortality rate is 0.8%. So that may be a little bit higher than what their baseline mortality, if they didn't have SARS-CoV-2 infection, was. Maybe that's an increase from 0.6 to 0.8%, for example. I mean, we can't say exactly. But in absolute terms, it's a very small difference in mortality. And I think we now need to start to weigh up the benefits of delay to the individual patient and the small improvement in mortality in some of these low-risk patients versus the impact both on those individual patients and the greater population of patients of delaying patients, of reducing the throughput of patients going through theatre so that our waiting lists are growing. We have a backlog of surgery we're not dealing with. So I think we need to sort of start weighing those two things up. It would be great to minimize the risk as much as possible to patients, but sometimes the benefits of putting in onerous processes might be a very, very, very small difference, absolute difference in mortality. And maybe that's not justified at this point. What do you think to that, Anil? It's quite a...
Just before I ask, do you have any further breakdown of this data to show?
So I think, no, I think Marcus asked, does this hold true for both elective and emergency patients? The answer is we've combined elective and emergency patients to make these charts, because when you start sort of to drill down into subgroups, some of the numbers become quite small. And so the denominators are quite small and maybe the numbers are less meaningful. So we've combined them for this. But I think the general pattern would hold true, that asymptomatic patients are lower risk than symptomatic.
But to add on to that, we've seen this from COVIDsurg 1 throughout. The actual operation has less to do with it than the patient risk. There's an appendectomy in an 18-year-old with SARS-CoV-2. And then there is an appendectomy in an 85-year-old ASA 3 to 5 with SARS-CoV-2. And what that first wave showed is they're not the same. And what I think this shows us is they're not the same. So I think the operation type is actually less important than the patient risk. So yeah, Dimitri, to go back to your question, would I be looking to lift some restrictions? I think the restrictions around bringing patients into the hospital, the isolation, the testing, have led to significant capacity problems. Whereas I can look at this and say there's some patients who don't need that if they're vaccinated and asymptomatic. I would look at this, Dimitri, and say if someone's unvaccinated, I would probably be more cautious. Do you think there's any benefit in testing an unvaccinated patient, or does the fact that they meet me and I haven't had a test negate that?
Yeah, I think if someone's asymptomatic, the difference here between the vaccinated and unvaccinated patients isn't very significant within the asymptomatic groups. So in the second and the fourth column, they're relatively similar, really. And that kind of makes sense because the symptoms are a marker of the severity of the SARS-CoV-2. So if they were going to have a poor outcome, they would probably have more symptoms. So whether or not they were vaccinated. So I think the benefits of testing unvaccinated patients are probably less, just because if we're not going to change their management, then is it useful to test them? I think that's certainly true in the lower risk, younger, fitter patients. That might be different in the older comorbid patients. I agree. So I think maybe Paul Miles has asked a question, and I think there was an earlier question about how country income might change what we see. So I think on the next slide, we break things down a little bit by country income. So as I mentioned earlier, the overall mortality rate is 5.8%. But when we split it by income, so into high income countries and low middle income countries, we can see the mortality is higher in the low and middle income countries. Now, that's not a surprising pattern, because we've seen in many previous studies that, sadly, related to many different factors, mortality is higher in low middle income countries than high income countries. However, when we drill down and look at the mortality in the unvaccinated and vaccinated patients, we can see that unvaccinated patients in low and middle income countries have a much higher mortality rate than the vaccinated patients. So what I mean by that, in a low and middle income country, vaccinated patients have about 6% mortality, whereas the unvaccinated patients have about 12% mortality. So it's about doubled. This isn't risk adjusted in any way, but just roughly the mortality rate is doubled. In high income countries, that difference is much less. So in the vaccinated patients, mortality is 4.5%, and in the unvaccinated, it is 5.3%. So there is a benefit to vaccination in the high income countries, but it would seem that the benefit is greatest in low middle income countries. So why might that be? Well, in the low and middle income countries, what we find is that if you are unvaccinated and you have a postoperative pulmonary complication, your mortality rate is 41%. So that is really very high. Whereas the mortality rates in the patients with pulmonary complications in high-income countries are a bit lower. So it would seem that the vaccination is important in low and middle income countries because it reduces the number of pulmonary complications patients experience. And that is what's leading to patients dying. And then when they do experience, if a vaccinated patient has a postoperative pulmonary complication, the mortality rate is lower. So vaccination seems to reduce pulmonary complications and reduce their severity. And that's true in both income settings, but it has a greater effect in low middle income countries. So I think broadly, the patterns we see are the same across the world, but the magnitude of difference might be a bit variable.
So I think this is really important because this is what we would call a sort of, theory model which links the outcome to the event. So it's not just someone's commented that death is crude, but by inserting the morbidity here, you've sort of linked the chain of events from surgery, vaccination, morbidity, mortality, which I think is important. What I'm taking from this, there are differences in income, and I don't think, Dimitri, we're designed to detect all the why those differences exist in this study. We have looked at that in previous global surge studies, but what this tells me is sort of what you said, that vaccination is protective in all resource settings, and that's really important.
Yeah, and I think there's obviously many people have talked about this, but there is an aspect relating to vaccine equity that we need to make sure as a global community that all patients have access to vaccination around the world. Because do
you know off the top of your head, and sorry to interrupt, in forgive me if you don't know this, in the high income group, how many of the elective patients were vaccinated?
I don't know by proportion, but I think you have to be a little bit careful interpreting these vaccination rates, because these are obviously patients who were vaccinated who then had SARS-CoV-2. there will be potentially many patients who are vaccinated who simply don't develop symptoms, don't test positive, they have very, very mild infection that goes undetected. So I think trying to tease
because
out
of the vaccination.
Because of the vaccination. So I think trying to understand so I guess what I'm saying is the proportions we see here may not mirror the proportions of patients who are vaccinated overall, if that makes sense. So I think we just need to be a little bit cautious. So I think just to kind of finish up on the vaccination, really, we've looked at adjusted models where we've tried to, obviously there might be a lot of bias confounding because of what kind of patients get vaccinated, what are their ages, are they fit, unfit, are they having elective or emergency surgery, etc. So we've tried to do adjusted analyses, which have adjusted for these potential confounding factors: age, sex, ASA grade, revised cardiac risk index, urgency of surgery, minor major surgery, whether they had a general anesthetic, the country income level, and so on. So we've tried to adjust for that, and we've come out with these odds ratios. So just as a reminder, I'm sure everyone's familiar, an odds ratio of less than 1 indicates that the odds of an outcome are reduced. So in this case, we're looking at what are the odds of mortality or postoperative pulmonary complications in patients who were vaccinated versus unvaccinated. So an odds ratio less than 1 means the risk in vaccinated patients is reduced. And obviously, the lower the odds ratio, the greater the effect size. And what you can see here is that all the odds ratios overall in high-income countries, low-middle-income countries, mortality, postoperative pulmonary complications, in each case, they're less than 1. So, and they don't cross over 1 in the 95% confidence interval, meaning these are all statistically significant results. So what we can say is that vaccination significantly, very substantially reduces both mortality and postoperative pulmonary complications around the world. And as you can see, the impact on mortality is greater in low, middle than high income countries.
So what I take from this is, and so we've got about 10 minutes left, Dimitri, so we'll get into our summary of recommendations. But what I'm taking from this is that if I see an elective patient, I should routinely check that they are vaccinated before I operate on them. If they're not, they should get a vaccine. What I'm also taking from this is if I see an emergency patient and it's life-saving, fine. If it's an appendicitis and they can't wait, fine. If it's something I can expedite, so something I can pause and do again in a patient who has risk factors, I'm thinking sort of old unvaccinated hernia patients with COPD. I might vaccinate them and pause. I'm not now. I don't think we're going to come out and say there are going to be absolute recommendations here. I think the world has moved on from that, but which is what you're getting to. But those are my thoughts, and I'm just giving a couple of examples. So here have you sort of given us an example of risk?
Yeah. So I think our thinking is that it's quite difficult to make absolute recommendations because there's lots of different factors that might come into your risk assessment. So what we've suggested here is trying to categorize patients as lower risk or higher risk, and to look at a number of factors. So low risk patients would be patients who we would consider classically to be low risk surgical patients. So their age is less than 70, their ASA grades are 1 to 2, they're not, they're fit, younger patients. But we can add to that these are also patients who are up to date with their SARS-CoV-2 vaccination. These are patients who have asymptomatic infection. So that's what a low risk patient might look like. We might also think about what our health system is like. And I think some of what we've looked at, the differences between country income settings, perhaps we might suggest that having the ability to access critical care facilities to manage severe pulmonary complications, that is something that might reassure us, because, if the patient runs into problems, we will be able to manage them. But if we're in a setting where we don't really have critical care facilities, we might worry that actually, if a patient does get complications, we're not going to be able to manage them, and they're more likely to die. Higher risk patients, they might be patients having major surgery, although, as we've said, that is less important probably than the patient characteristics. They're patients who weren't vaccinated, patients who've got symptoms, patients in communities where there's a high infection rate, meaning that they're more likely to be infected just by chance, because everyone in the community is infected. So, your patients will not eat sort of fit neatly into low risk or high risk. I think there's a bit of a judgment call based on multiple factors to kind of risk assess and think, overall, this sounds like a lower risk patient. Overall, this is a higher risk patient. Do you think that would be useful kind of decision aid to use, Anil, when you're making decisions for your patients?
I think it will. I think, there's so many risk scores out there and things like that. And I don't think anyone quite agrees what high risk and low risk is. And I make judgment calls every day. I think that's what we do in clinics. That's what we do on the wards. And this helps guide us. What I am taking from a lot of this, Dimitri, is that this concept of symptomatic and asymptomatic is now really important to us. And in my mind, I will have a lot more flexibility and relaxation over the asymptomatic patients, and not quite the asymptomatic lower risk patients, whereas the symptomatic higher risk or the asymptomatic higher risk, that's an important group, isn't it? This asymptomatic higher risk, you can't just say everything's going to be fine in them, but that's how I'm beginning to think that you can begin to stratify these people. I definitely don't think we can just say, across the board, forget about COVID and surgery. I think it's an ongoing issue, and the data proves that. But what I am taking is that this concept of symptoms and risk is what the next sort of 3-5 years is going to look like for patients and planning.
Yeah, and I think there's a bit of nuance here. I think that you go on Twitter, you read the newspapers, the kind of discussions around COVID have become quite polarized between people who, some people who believe that COVID is still a massive threat and we need to think about lockdowns and lots of restrictions, and people who think that COVID has gone away, it's not a problem, we don't need any restrictions at all. So I think the reality is a bit more complex, and we need to take this kind of risk stratified approach. Depending on the patients, we need to manage them differently, so that we can keep as many patients as safe as possible whilst maximizing our ability to operate as many patients as possible. There's a balance there that I think we can manage with a bit of thoughtfulness. So
just before I talk, I just got some specific thoughts about these patients. Do you have a summary of what the findings or recommendations are? Or yeah, okay, here we go.
Yeah, so I think it's just to reiterate what you've said. I think anyone who's having surgery, particularly elective surgery, we should make sure they're up to date with their SARS-CoV-2 vaccinations preoperatively, if possible. Sometimes patient with aggressive tumor, there might not be time to get them vaccinated, but vast majority of patients, we can probably wait a couple of weeks for them to be vaccinated.
So let's unpick these one at a time. And some people might say, and look, we'd be delighted to hear from everyone over the next couple of days via whatever medium you can on how these fit. I don't think the conclusion to all this is going to, I don't think the abstract conclusion is going to be a single line. I think the conclusion is going to be a few summary messages that will change global practice. But what I take from that is still, only 2/3 of patients are vaccinated. So some people will turn around and go, yes, that's obvious, that's a recommendation, but this really does reinforce the importance of this subgroup. There are no other reasons at the moment people are walking willingly into a hospital except for elective surgery. So I think that, that really does, I think that's important. That's a good headline message. So number one. Number two?
Yeah, and I think just to kind of add about the vaccination, we have looked at the impact of whether you've had a partial vaccination, a full vaccination with 2 doses boosted. I think the reality is that study wasn't really designed to address that in detail. So I think our recommendation would be, when we say they should be up to date with their vaccinations, that you should just follow the national guidance in your country for whether patients should be boosted and when that should be done. I think we'd take a pragmatic approach to that. So the next bullet point is just to say, I think for low risk patients, and we've sort of talked about what low risk patients might look like, we probably can think about lifting most restrictions. There probably isn't a huge amount of benefit, for example, in testing patients preoperatively if we're not going to then delay their surgery, if we're not going to ask them to isolate. So I think for the low risk patients, we can really think about making things as streamlined and straightforward as possible.
So that's the key one for me. I would only test someone if I'm going to delay their surgery. I don't think patients will isolate anyone. I think I will struggle to isolate them. And I think, within our hospital, the true COVID-free environments have gone. But if I test them and I think I might delay this patient because of that, then that's a really good reason to test patients. Otherwise, if I think I'm going to get on and do this no matter what, it's very low risk surgery, for example, a day case procedure in a younger patient, then I can probably lift all the restrictions around that patient. So that for me is really practice changing now.
Yeah, and I think that's also important, because doing tests and then somebody tests positive, there is a risk that even though you're happy to operate them, it might cause a bit of confusion in the wider team and unwarranted concern. So I would just probably try to avoid that, in the same way that we don't routinely screen patients for influenza. I mean, we could go out and swab everyone for flu, but we don't do that because we don't think that would be beneficial. But if someone was symptomatic, somebody came symptomatic, then you might think about testing them. So this is what we're saying. For the higher risk patients, we do think we should be screening those patients preoperatively, because a positive test in a high risk patient probably requires a different response, which is we should probably think about delaying surgery if someone is higher risk. Now, how long we should delay surgery for? Well, we don't have any new evidence, because our study only included patients who were operated up to 7 days after a positive test. So we don't have the data on patients who were operated several weeks after their positive test. So we can't say what the optimal delay is. I think a safe thing to say is, well, we know from the past that delaying for at least 6 weeks in the first wave was safe. So I think if you've got somebody very high risk who can wait, then 6 weeks is probably sensible. If you've got somebody sort of intermediate risk and you really want to get on, well, maybe there's a judgment call about delaying their surgery for a shorter period of time. I mean, I would certainly say we should delay them until their symptoms resolve. So I think there's a bit of a judgment call there. And I think the third thing is, as we think about how we design our surgical pathways, we still need to probably maintain some COVID-free post-operative environments. So the kind of COVID-free, green, COVID-light pathways that people have talked about in the past. I don't think we necessarily need that for all patients, but it's probably beneficial for some of the higher risk patients who, in whose case, being infected by another patient, by a staff member, might be particularly worrying. So, bit of a risk stratified approach there, I think.
So vaccinate. We're going to run out of time, Dimitri. So vaccinate and generally start relaxing restrictions. So look, Dimitri, that is practice changing data. I think that will sort of allow us to guide our surgical services for, I think, at least the next 5 years. So in terms of publication, we're going to look to get this data. We'd appreciate feedback in the next 48 hours and then submitted relatively quickly.
Yeah, so we'll get this submitted, I think, in the next week or so. Obviously, I think Mikola is asking for when it's going to be published. I mean, that's obviously quite difficult to kind of to say. Depends on journals and things, but we're going to work to get it done as quickly as possible. Just to answer, there was a question, I think, about what about patients who refuse vaccination. Obviously, I think we need to counsel patients about the importance of vaccination, but if patients decline that, then we just need to manage them, I think, as being a higher risk patient and sort of keeping some of these precautions in place.
So big supplement to this paper, I suspect, where we'll get all the data out, which is great. So look, Dimitri, kudos, well done to the collaborative. Looking forward, number one, we'll move toward publication. Number two, we are happy to present this really widely and broadly. A lot of that's going to be over Zoom, but to your hospitals, to your surgical associations, to your national groups, we'd be delighted to present. Can I tell you about just a couple of upcoming things? On the 31st of October, we are publishing 2 papers. Our group is publishing 2 papers in The Lancet. One of them is the CHEETAH trial, which is change of gloves and instruments before wound closure to prevent infection. Should you be doing it routinely? The second one is about elective surgical system strengthening. So the resilience index, the surgical preparedness index, which many of you would have contributed to. So how well prepared is your elective system for this winter? We know the index tells you for every 1 point increase in the index, you will increase your elective capacity by 3.6%. So the resilience paper we're going to launch via a webinar, which we're aiming for November the 28th. We will send out the data on that. That takes the systems-based approach to what's important around the world. And on the 16th of January, we'll be discussing the CHEETAH paper. That's going to be slightly different, this SSI webinar, which comes from our global surgery unit. So we'll do it twice to accommodate for people's different timings. But that will be a slightly more in-depth webinar. We'll have breakout rooms into patient involvement, into health economics of CHEETAH, into implementation of CHEETAH. And we'll be presenting the first look at the health economics results within those rooms as well. So please, we'll send out those details via our email list and on our Twitter account. So look, Dimitri, I think we're going to close. Well done. Really looking forward to seeing this being published as soon as possible, in time for winter. And thank you very much for all your hard work and for everyone else on it. So well done, Dimitri, and thank you, everyone.
Yeah, huge team effort. So thank you, everyone who's contributed, and look forward to continuing to work together in the future. Thank you. This
will be out on YouTube, and we'll begin disseminating information as fast as we can, but I'm going to bring it to a close there. So thank you. Good night, everyone. Good morning for wherever you are. And take care and goodbye. Bye-bye, Dimitri.
Bye-bye. Bye-bye.